Hey, thanks for having me. I'm Dr. Andrew Mendlowitz. So I'm here to talk to you all today about infants born to those ever diagnosed with chronic infection. This research has since evolved. So before I start, I have no conflicts of interest to disclose. Also, thank you to the conference organizers for having me. I forgot. So first, Hep C rates are increasing with over 20% of infections occurring among persons of childbearing potential. Now, a recent meta-analysis saw a vertical transmission rate of 9% with odds up to 3 times higher in HIV co-infection. And from our previous work on the Hep C prenatal and postpartum cascade of care, we observed poor rates of linkage to care and treatment initiation following first pregnancy, and these rates were as low as 1 to 11% at 1 to 5 years postpartum. So as mentioned in a talk by Dr. Biondi earlier today, for infants with perinatal HCV exposure, antibody testing is recommended on or after 18 months. Less than 18 months is not recommended based on persistence of maternal Hep C antibody. Hep C RNA testing is recommended at 2 to 6 months, promoting early diagnosis and linkage to care. Earlier is not recommended based on limited sensitivity. So building on our previous work that identified opportunities for engagement in hepatitis C care and treatment during pregnancy, the goal of this study was to focus on infants ever born to persons Hep C RNA positive in Ontario and characterize gaps in Hep C testing and care. So to do this, we performed a retrospective cohort study using health administrative data looking specifically at infants born after September 2007 to likely RNA positive mothers. And we looked at testing overall, and we performed a landmark analysis at and after 2 years from delivery. So in Ontario, we're really lucky to have this wealth of administrative health data housed at ICS. And ICS contains patient-level data of routine care, health claims, and prescription claims. And this is included for all people with public health insurance in the province. And at ICS, they have a data set of inpatient-linked pregnancies that were carried to greater than 20 weeks gestation. And what we did was we linked this data to Hep C testing records spanning 1999 to 2022. So we took our previous cohort that we established and have shared the research on that consisted of pregnant persons ever Hep C antibody positive. And for this, we focused on pregnant persons ever RNA positive who likely did not clear or receive treatment for their infection. So we specifically focused on infants we could link that were born after September 2007, as that allowed us to use laboratory data that included primary care submissions and captured negative testing better. And we followed these infants from birth to December 31st, 2022, and ensured a minimum of 2 years of follow-up. Now, one thing I just want to highlight, and I'm going to visit throughout my talk, is for a sensitivity analysis cohort, we also considered infants born to those who were antibody positive but not tested for RNA, as it may include some chronically infected. So just looking at some of the pregnancy characteristics we observed. So at time of delivery, the majority were from urban areas and 9% had records of immigration. In terms of pregnancy outcomes, we predominantly saw C-sections, although this number was slightly lower than what has been observed in the country, and we did see a higher rate of postpartum hemorrhage. One thing I want to flag is that 54% in our cohort had record of substance use prior to delivery. Now, looking at infant characteristics, 36% of infants were born to those who first tested RNA positive prior to and during pregnancy. And you're going to see this cohort referred to a few times throughout this talk. And to do that, I've highlighted them in this blue color. 64% of infants were born to those who tested RNA positive after the pregnancy. Of infant outcomes, we saw that 30% had a record of neonatal abstinence syndrome, which we flagged as an ICD code corresponding to diagnosis of withdrawal from maternal drugs of addiction. And we did see this higher amount of preterm birth. So just first focusing on our entire cohort. And what I want to flag here is infant testing was low. Only 24.8% of infants born to persons ever diagnosed with chronic Hep C were ever tested. And that corresponded to around 25% being antibody tested and 7% were RNA tested. Now, not represented on this graph, what I want to flag is for our sensitivity analysis group of those infants born to pregnant persons who were antibody positive and did not have an RNA test, we saw that only 7.3% of them were ever tested. Now, looking specifically at infants born to persons diagnosed prior to or during pregnancy, 40% of those were ever tested. And what I want to flag is that 11.4% of those ever RNA tested were RNA positive. So this can be seen as like a proxy or surrogate measure for mother-to-child transmission. Now, we wanted to see, how does this look in practice? So we focused on, where does that first antibody test actually fall? So among those in the group where the pregnant person was diagnosed with Hep C prior to or during pregnancy, among those antibody tested, we observed there was a median of 18.1 months to the first antibody test. So from that median, though, you can tell that nearly half had their first antibody test prior to 18 months. And this creates concerns in interpretations of findings, especially around persistence of the maternal antibody. If asked how many of these infants were subsequently tested properly, only 67% were ever tested correctly. Now, looking at RNA testing in this group, among those with a test record, there was a median of 6 months to first RNA test. And so this translates to around 16.1% with their first RNA test in less than 2 months, with that risk of that misleading result. Now, I am limited on time, so I can't comment much on infants born to those diagnosed after pregnancy. But if we look at the stratified cascade here, only 16.6% were ever Hep C tested. Now, we did do a deeper dive into this group to understand how could these infants be tested if the pregnant person didn't even know they were RNA positive at the time. And what we saw was 64.2% of these infants were tested within 2 years of the mother's earliest RNA positive, and 4.2% were ever tested were Hep C RNA positive. When we did a deeper dive into these infants, most of them were born with neonatal abstinence syndrome, or the mom had a record of substance use, and we also saw that these tests were relatively actually closer to their mother's antibody positive. So we conducted this landmark analysis following both groups to their earliest test and sensor date. And what we observed is, for those born to persons diagnosed prior to or during pregnancy, we saw around a probability of around 29% being tested by 2 years. For those born to persons diagnosed after, we saw an event rate of 8% by 2 years. Looking at that restricted mean time to event for that first 2 years, on average, patients in that prior during group had a 3-month shorter time to Hep C test than those in the after group. When we fit a model to look at associations with testing in this group for the first 2 years, out of all our factors we looked at, we saw infant number of physician visits, female sex, and the mother having an HIV diagnosis as having the most significant impact. So looking at those after the 2 years, what's concerning is these lines get a lot closer together. For the prior group, for the prior during pregnancy group, infants born, we saw an event rate of 20% tested by 14 years post-delivery. For those born to mothers that were diagnosed after, we saw an event rate of 12% tested by 14 years post-delivery. Once again, looking at that restricted mean time to event for that 12 years, on average, infants in the prior group only had a 1 year shorter time to Hep C test than those in the after group. And when we fit a model of predictors here, we only saw female sex and number of pediatrician GP visits really impacted. So in both these models, we're still further exploring, but we're really seeing a limited impact of maternal factors on predictors of infant testing. Now, one of our last objectives was to create a rough estimate and range of how many infants were likely in this period with chronic infection. So to do this, we used our overall cascade to get the number of untested and RNA positive infants born to those diagnosed with chronic infection. And we took this and we also looked at certain conservative assumptions for vertical transmission rate, infant spontaneous clearance rate, and female spontaneous clearance rate. And the reason we used a conservative assumption for vertical transmission rate is the number we observed, this 55 and 14.8%, was a relatively slightly higher than literature estimates. So we just wanted to be conservative here. So when we first consider these assumptions together and look at infants ever born to those RNA positive, both tested and untested, we saw a range of 186 infants, as a range as low as 102 and as high as 305 infants that may have chronic infection. But if we consider our sensitivity analysis cohort, which is infants born to pregnant persons, once again, that were not tested for Hep C RNA, yet antibody positive, and incorporate that female clearance rate, That gave us a range of 114 to 398 infants. But one thing that is really incredibly important to stress here is that in addition to our conservative assumptions, this is really just the tip of the iceberg. If we consider how many individuals that are not tested for Hep C, you can just estimate that the rates may be up to 5-fold higher, especially if we base it on that 20% screening uptake rate. So in conclusion, what I just want to iterate is, first thing is, we observed how suboptimal infant testing is. Across the entire cohort, only 25% were tested. That was 40% of those born to pregnant persons who were diagnosed prior to or during pregnancy, and 16.6% born to those who were diagnosed after. Now, we observed that pediatric Hep C testing is more likely with a known diagnosis in pregnancy, not surprising. But we observed that among infants born to those diagnosed post-delivery, their children may not be tested for many years. So this may actually underscore the need for recommendations regarding screening children born to people who test positive after the pregnancy. We did see significant testing issues and delays both early on and following delivery, and we did see that limited impact of maternal factors on this. And once again, we did see as low as 114 to as high as 398 infants with chronic infection. And this was over that period of September 2007 to, because we restricted to a minimum 2 years follow-up time, December 2020. So this is likely just the tip of the iceberg. And with that, I just want to thank the research team involved, and I welcome any questions.